No, so I'm scared. I don't want to say the wrong thing.
Here you go, you get the best chair.
Yay!
Yeah, we're talking to the doctor now. I'll call you back.
Okay.
Okay, Sam, top of the round.
So it gets better during the day or doesn't?
It gets better after I'm medicated, after I've taken something for the pain.
Okay.
But if I don't, it gets
And what do you usually take? The ibuprofen?
I take the ibuprofen, 800 milligrams of ibuprofen, and then I take 2 oxycodone 5/500 milligrams because one hasn't worked by itself in a long time. Even 2 still like barely put a touch in it, but.
And you do that pretty much every day?
Yeah.
Okay. What else do you take?
Hydrea 1,000 milligrams.
And how long have you been on that?
For about like 9 months. For about 9 months.
Okay, does that help?
I really, I don't know. I really don't notice. I'm still in pain, so I don't know. I don't know.
Okay. But you haven't noticed a dramatic difference?
No, I haven't.
Okay. All right.
Folic acid. I think it's 1 milligram. I said Hydrea, Lexapro.
We'll come back to that.
Oh yeah, and for pain, I rotate in between oxycodone and hydrocodone. 7.5/500. We just went to that. And that rotate in between is the oxycodone, then the ibuprofen, then the hydrocodone. It's like you rotate in between, so I'm not taking, I'm not over taking one. So it's like rotating. And that way I don't have a tolerance to the other either.
Okay. Okay, and what do they treat you when you have to be admitted?
Dilaudid. I take 1 of Dilaudid when I get into the ER. Well, 2 of Dilaudid when I get into the ER.
2
milligrams.
2 milligram, 1. Okay.
I think that's it.
You're talking about for as an inpatient or as far as ER?
Both.
ER.
ER is fluid boluses, Dilaudid. Usually they'll start off depending on who it is and what kind of comfort zone they have, because they don't want to just give you 2 of Dilaudid. They don't really know anything about you. But they'll start off 1 of Dilaudid. Start IV bolus of D5 quarter.
Yeah, D5
quarter NS. Bolus of that, give 1 of Dilaudid, and then in an hour or
30 minutes.
30-minute increments, give another dose of Dilaudid.
And does that work?
Yes, it does.
Well, it depends on where you're at.
Yeah, it depends on where I'm at with the pain, but either that medication, whether it works immediately or whether it takes some time, it still is knocking out. Just depending on how much pain I'm in, it might take a little bit longer. That's what I mean.
So, and then when you're admitted?
The same IV fluid.
PCA. We go to PCA, and we go down to either 0.2 or 0.3, where I push it and I get point so and so of Dilaudid whenever I'm in pain as needed, and then sometimes one of Dilaudid, 1 whole unit of Dilaudid for breakthrough, and then for the chest pains, because recently over the past year I started developing chest pains. Dr. Class called them bone infarcts, but the chest pain has been getting worse and worse, and it's it went from right here, but it's like right here.
Okay, in the sternum. Okay.
Yeah. Yes. And so we take 1 of Toradol for that.
And Toradol too. Okay.
Yeah, for the chest.
With that, they have to be a little careful, because I think it's with the liver. You can't get too much.
Yeah, 5 days, and then you have to stop it. Okay. And so the pain is the main problem you have with sickle cell now.
Yes.
And any other complications from sickle cell?
Not that I know of. I haven't had a stroke, not that I know of, and so.
Okay. And were you doing TCD when you were?
Did I do what?
Transcranial Doppler, were they doing that? Were they?
I have no idea.
At Scottish, right?
I have no idea.
If they did, I don't remember that. I'm not saying they didn't do it,
okay,
but I don't remember.
All right. And acute chest or pneumonia ever in your life?
No, not to my knowledge.
Okay.
Yeah.
No, every time we go in, like more frequently when she started complaining about chest pain, then they started checking for the acute chest. But every time so far, that's been
negative. Okay.
Correct.
All right.
And she had this last admission of the VQ scan.
Okay.
And that was negative also.
Okay. And so, no leg ulcers, no other complications that you know of? And
yeah, that I know of.
You've had bone infarcts in the chest. Anywhere else?
Yeah. Not that I know of. It's a new pain to me, so I'm not really that familiar with it. All I know is that when it hurts, it hurts, and it's just been hurting in my chest. And I know that I know how the sickle cell pain feels in my back, but other than that, I don't know.
Okay. All right. So now the hard question. So certainly with almost all of the patients that get into the 20s, they have more problems with their sickle cell. And now that I have a large number of patients who are in their 40s, 50s, and 60s, and in fact there's been a study of patients who were over 60, once you get older, the pain gets better again. Okay? Most of my older patients tell me that that's because they learn to control their disease. And when they're young, they keep trying to push themselves and do everything they'd like to do, and that keeps making them sick. And once they learn how to adjust to the disease and control it, the pain, settles down again, and then they get on with their life. But the way you've been telling me about your pain, it sounds to me like you really don't want it to interfere with your life. You want sickle cell gone, and you don't want to have to deal with it anymore. Is that fair? You wouldn't consider living within the constraints that sickle cell put on your life presently, because you can't take trips, you can't do the things you want to do. Is that a fair statement?
It's a fair statement. It's a fair statement, but if I had the option to not live in pain, not wake up with my back hurting, not have to take medication and like wind up, because the only way that you get out of the pain is take your medication and you hydrate and you sleep.
Okay.
And if I had the option, yeah.
Okay. And so, how far have you gone in school?
College.
Finished or?
No, I'm like a senior, like a little bit above 30 credit. Well, 30 credit hours, probably around like 45 hours to graduate. So.
Okay. So are you having trouble with college?
I had
getting sick and having to take time off?
I had to do a hardship withdrawal the last semester, and it's just kind of starting to impact school.
And where are you going to? What are you studying?
I was studying film and video, but I was looking to switch into more so into being in front of the camera, the acting and everything else.
Okay, so that's what you want to do for your career choice.
Yes.
Okay. Did this start with college?
No. As far as acting?
No, the pain.
Oh, excuse me.
Increase in pain.
The increase in pain, I don't necessarily know right off the top of my head. I think I started having to make more classes and stuff like that. So yeah, things did start kind of getting a little bit more stressed stressful, but the sudden onset really not so much until I started traveling. I started really traveling. Then that's when everything really started coming up, and then it just went from there. So.
Okay.
Yeah.
Any allergies?
I'm allergic to the pneumonia vaccine.
Okay, when was the last time you had that?
Like about seven, maybe 8 years ago.
What happened when you had it?
I started running a fever, high fever. My arm swelled up to the size of my dad's arm, and it maybe even bigger. And I just remember being cold, sweating profusely, but I was cold, but at the same time I was running a temperature, and yeah, it's just that's what I remember, and my arm swelling up. So.
Okay. Anybody else in the family have sickle cell?
I have a cousin who does. And he just had a stroke last year.
How old is he?
I think he's like 17.
Okay.
We have
And then
the mother's, what's that one?
we had an Aunt Mary.
Yeah,
She died of sickle cell disease earlier this year.
I think she was 40.
I don't know how old she was.
She was around my wife's age, so plus or minus 5 years from 40.
Okay. Any other things running in the family? Diabetes?
My father, her grandfather, was diabetic and high blood pressure.
Okay. Anything else?
My wife has high blood pressure. And as far as our family goes, asthma. I have exercise-induced asthma. My daughter has asthma. And I think that's about it.
Okay, and 4 brothers and sisters?
My back is hurting now, so.
Okay, so in terms of what the outcome, the expectation for the transplants, what did Dr. Waller tell you?
Expectation? I really haven't really heard anything about expectations. It's only been like a hypothetical, not what to expect.
So what did he must have told you what it entailed. You sort of described it physically, but what are the risks that he outlined?
Graft versus host?
Yeah, graft versus host disease, then latent graft versus host, a possible infertility.
I think he said weight gain, possibly.
It depends on what kind of medication.
No, I'm trying to think of all the things he said that were possibilities.
Death. That's really, I'm trying to think, that's really what I can remember off the top of my head.
Okay. And how long was he planning that you'd be sick from it?
He said he said look to be at least a year process. And he called out best and worst case scenarios, and everybody varies. So maybe 6 months, but you could count on like a year.
Okay. All right. Yeah, and so I'm going to just do it in real broad strokes because later on we'll have to go into it in detail. But the studies that have been done in adults so far, we've used non-myeloablative transplants, and which means that we don't use intensive chemotherapy to completely get rid of your bone marrow and try to establish what's called stable mixed chimerism, where you have both your bone marrow working and the donor's bone marrow. And because the cells from the donor last longer, the experience has been that completely replaces the sickle blood cells, so that you essentially become normal in terms of the hemoglobin type, and that takes about a year of preparation, the transplant, and then immune suppression afterwards to make sure that the graft takes. One of the major complications we're seeing, and we saw in pediatrics, was that you actually rejected the graft, and your sickle cell bone marrow grew back again. And then if that occurred, we wouldn't improve your disease probably at all, and you would have gone through the transplant for nothing. And that occurred in children at about 15%. We don't know if it's going to be lower or higher in adults. The NIH has had the biggest experience with transplant, and they've done now, I think, about 12 or 15 individuals. And their strategy is different. They're doing the non-myeloablative, but they're leaving people on immunosuppression, probably for life, because they're worried that the bone marrow will be rejected later on. And we're not doing that. We're contemplating trying to stop the anti-rejection therapy after about a year, and letting your immune system recover completely. And certainly infection and bleeding are potential complications acutely during the transplant after you've been given the medications to essentially get rid of your marrow and before the new marrow takes over. And then later on, the graft versus host is a major concern. Now, saying all that, the results have been very good. The one thing that has not happened as quickly as we had anticipated is that the pain doesn't always get better immediately. And the experience with the NIH has been that very often they get a complete resolution of the sickle cell, but individuals continue to have pain. And sometimes it's related to being on very high levels of the opiates and then having to taper off those. That wouldn't be a problem in you because you're using very little in terms of regular opiates. So that should be quicker. But if the chest pain and the back pain is coming from bone infarcts, it may take a while for that to heal up before the pain would be relieved. Okay? And so I wouldn't expect instantaneous pain relief. About 60% of patients, get really good rapid benefit in terms of pain relief. But in a significant number of patients, the pain persists, and that has to be dealt with separately. And I can't predict that. But that would be one of the reservations we'd have with the treatment. Okay. Have they done back X-rays?
Back X-ray? I mean, I've been on that little board thing, and they took the picture from the front, but I haven't laid on my stomach and have them take pictures from my back.
No, I mean, but they were X-raying the back.
No, they were X-raying my chest, but.
Like a KUD or something like that.
No, I would recommend that they do actual films of the back to make sure that there's nothing else causing the back pain, because there are a lot of different causes for back pain, particularly if you're waking up with it every morning. To me, that doesn't sound like that it may be directly related to sickle cell, and you may have some other back problems that are contributing. I would definitely, has Dr. Class put you on an exercise program for your back?
No.
And I will recommend that she actually send you to physical therapy to see if some back strengthening and back flexibility things would improve the back pain directly.
Okay.
One, so you're not suffering. It wouldn't change the idea of having a transplant or not, but it would, if we could get rid of the pain sooner, that would be fine too, right?
Yeah.
Okay, all right. I think for you, if you did change lifestyle and lived within your disease and slowed down, your pain might get a lot better.